Hello and welcome to the April 13th episode of APHA's 15 on COVID-19 series. Today we're going to be talking about convalescent plasma. My name is Dan Zlott. I'm the Vice President of Education at APHA. Thank you for joining us. Let's go ahead and jump right in. I have nothing to disclose as usual. Learning objectives for today. At the end of this activity, you should be able to discuss the latest developments related to COVID-19. All right, so you may have heard very recently a lot of discussion about convalescent plasma in particular for COVID-19. It may surprise you to learn that this is not a new idea. So the whole premise here is that we take plasma from an individual who's recovered from a disease and we give it to a person who hasn't. So either they've just been exposed or maybe they're starting to become ill and we want to convey passive immunity. So this is a way of transferring, as I said, passive immunity. And that's as compared to active immunity, where our immune system learns the pathogen and develops a response. Here we're taking the response that someone else's body learned, and we're taking those antibodies from their plasma against whatever pathogen we're trying to target, and we're transferring it to an individual in hopes that those antibodies will help control the disease, in this case, COVID-19. And as I said, this is not a new therapy, so it may surprise you to know that this approach to treating infectious disease has been in use for over 100 years. And in fact, the reference that I've listed here is a meta-analysis looking at the use of convalescent plasma in the Spanish flu outbreak in the 1917-1918 period. So really very old. And in fact, there was work being done on this in the late 1890s. And in fact, people won the Nobel Prize for their work in convalescent plasma, in particular for diphtheria. So kind of interesting that this is a really, really old treatment modality, and yet we're looking at relying on it for COVID-19 until we develop better options potentially. So what are some of the advantages of convalescent plasma? The idea is pretty straightforward. We're just taking someone else's immunity in the form of antibodies and transferring it to another individual. So what are the advantages to this approach? Well, one of the biggest advantages, at least in modern day, is that our healthcare system is already set up to deliver significant quantities of plasma from one person to another. So if you've ever worked in a hospital or had exposure, if you've ever heard of FFP or fresh frozen plasma, it's a blood product that's commonly used when people are bleeding out rapidly, when they have clotting factor deficiencies, etc. So there's a number of different reasons we would use this. And so blood banks are already set up to process large quantities of FFP and store it and transfuse it into other patients. As I mentioned, one of the more common uses for this is intravascular volume depletion. Other things would include, as I said, clotting factor deficiencies. In the modern era, this is extremely safe. There's a lot of safeguards in place due to donor screening, testing procedures. When someone donates, those blood products don't immediately go into patients. They get frozen a lot of times, and then there's a lot of viral panels run to make sure that patients don't have infectious diseases like HIV or hepatitis, etc. So the risk of getting an infectious disease transmitted through a blood product transfusion in the modern era is about 1 in 2 million blood transfusions. So it's incredibly rare. It's a very, very rare event. So anyways, overall, very, very safe process. What are some other advantages? Well, in a situation like this where we really don't have available therapeutic options and we're still studying, we're still learning, this is one of the most rapid ways to deliver therapy during an epidemic or pandemic outbreak of an infectious disease. And so obviously, given our current situation, this holds a lot of appeal. It's an approach that's shown efficacy throughout the years, maybe throughout the decades. And in fact, for other coronavirus diseases like SARS and MERS, there have been studies that looked at this and there was some efficacy demonstrated. The studies aren't perfect, but the case series are, on the medium side, 80 plus people in some of the larger case series. So there's some decent data there that this is effective. Now, one interesting thing about this is it can potentially be used in a couple different methods. So we could use it for post-exposure prophylaxis, so before someone really gets ill, and potentially also for treatment of various phases of an illness. And we'll touch on that in a little bit. The other potential advantage here is that as the number of COVID-19 survivors increases, so does the potential donor pool. So that makes sense. You have more and more people who potentially have immunity to COVID-19, so the availability of donors and the availability of convalescent plasma therefore also potentially increases as this epidemic continues to progress through the United States and through the world. All right, so now let's talk about some of the disadvantages with convalescent plasma and some of the unknowns. In particular, this is true with COVID-19. The first one is that the appropriate dose is unknown. Typically when we think of administering a therapeutic agent, we have some idea of the dose range. Even when it comes to another plasma product like IVIG, for example, we have a general idea of the dose range. IVIG is a little bit different. It's a pooled plasma product, right, from a bunch of different donors. They screen them intensively, and then they pool all their sera, and then they concentrate the antibodies that are in there, and that's IVIG. But you don't really know exactly what's in there. It varies from lot to lot. You can do some testing if you really need to know if a specific antibody is contained in a particular lot of IVIG. You can do that assessment. We have general guidelines around dosing, but in this case, we're interested specifically in COVID-19 antibodies. And so we don't know what the appropriate dose of anti-COVID-19 antibodies are. Furthermore, we don't even know what's the most important subset of anti-COVID-19 antibodies. Is it IgA, IgM, IgG? Typically we think of IgG as providing the best protection longer term, and certainly in patients who have been exposed, IgG is the antibody that tends to stick around the longest. It's the later antibody in the response, the antibody response. And so it would make sense that it might be IgG, but maybe IgM plays an important role. So we're still learning. The other thing is we don't exactly know what the best antigen to test for when it comes to anti-SARS-CoV-2 antibodies. That's, of course, the virus that causes COVID-19. There are a number of different antigens on the COVID-19 virus that have been identified and that we've developed antibodies against. And we don't know what the best one is in terms of assessing activity against the virus. So that's an open question. Another open question is, what type of testing do we do? There's a concept of a neutralizing antibody versus an antiviral antibody. And so the difference between the two, a neutralizing antibody is assessed using a cell culture. So what they do is they, in a petri dish, essentially, you grow some cells that you know are susceptible to COVID-19 infection. You take someone's antibodies from their plasma and you put it in the dish along with the cells, and then you expose that to COVID-19. And so if the antibodies bind to the virus in a way that prevents the cells in the petri dish from being infected in the first place, that's called a neutralizing antibody. Not all antibodies are neutralizing. So in other words, they may bind to the virus, but they may not prevent the infection of the cells. There's maybe other benefits to that. So for example, those other antibodies may activate the complement system. So in a cell dish, you're not going to have the full complement system, which is an important component of the human immune system. That's not present in a petri dish necessarily. So you may not see that neutralizing effect in vitro, even though it's present in vivo in the human body. So another factor we're not sure about. So again, we're not sure what the right measure of anti-COVID-19 activity is in these convalescent plasma products. So what are some other disadvantages or unknowns? Well, one thing we're not sure of is the appropriate timing. So do we give this upon post-exposure prophylaxis? So after someone's been exposed, but before they're actually sick. So maybe we could give them a dose of antibodies and really, short circuit this whole viral infection process before it has a chance to take hold. That might be incredibly effective. We don't know yet. Is it best in patients with mild symptoms, moderate symptoms? Does it make sense to sort of, again, derail the disease process before it has a chance to progress on to more severe disease? Or is it really beneficial only in patients with severe disease? So these are all open questions. As you'll see in the literature we're going to take a look at, there's a certain subset of these that have been looked at more than others. And so we have maybe a little bit more insight there, but not a lot more, as you'll see. So again, another open question. The other potential large disadvantage is that blood banks and hospitals must recruit their own donors. So it's not like there's an IVIG product that's commercially available out there that contains COVID-19 antibodies, at least not yet. Maybe there will be down the road. But for now, that means that blood banks have to recruit patients who have recovered from COVID-19 and get them to volunteer to, donate their plasma so it can be used for treatment of others. And you may have heard right now there's a national shortage of blood products in general because people are hesitant to go into donation centers because of the fear of exposure that they might have in going to a collection center. And so it takes a lot of effort to recruit these donors. And then there's all the usual stuff of processing the plasma and everything else. That's pretty run of the mill, but it does require a significant number of donors to maintain an adequate and ongoing supply of convalescent plasma. All right. Well, now that we've got a little bit of a background about the advantages and disadvantages of convalescent plasma, let's take a look at some of the clinical evidence. So the first study we'll take a look at is a case report in 4 critically ill patients. So what I did is I looked at the paper and kind of turned it into a table. There wasn't a table in the document itself, so this is a little bit of an extrapolation. But let's just run through the patients. I'm going to go pretty quick just for the sake of time. So this is a case series in 4 patients. The age range here was from 31 all the way up to 73. The 31-year-old female in this instance was 35 weeks pregnant. Otherwise, these patients had some past medical histories that included hypertension, COPD, and one patient had hypertension and chronic kidney disease. So that particular patient was a very high-risk patient. They tracked the days from hospital admission to intubation in these patients, and it ranged from 1 all the way up to 5. And of note, there was one individual who was never intubated. He was mechanically ventilated with a non-invasive mechanical ventilation method. So that's probably, CPAP, BiPAP, something along those lines. When you look at the number of convalescent plasma transfusions that these patients had, anywhere from 1 to 8 convalescent plasma transfusions, so pretty open. And then when you look at the total volume of convalescent plasma transfused, anywhere from 200 mLs all the way up to 2,400 mLs, so a significant range, a lot of variability there. So then the next thing they looked at was how many days from the initial convalescent plasma transfusion to extubation. And so that ranged from 15 to 20. And as you'll see, there's 2 patients who weren't extubated. The 55-year-old male with COPD was never intubated, so therefore there was no extubation date. And in the 73-year-old male with hypertension and chronic kidney disease, at the end of the report, he was still intubated and in the ICU. And likewise, they also looked at days from the initial convalescent plasma transfusion to hospital discharge. And so that ranged from 7 all the way up to 26 days. Again, the 73-year-old male with hypertension and chronic kidney disease was not discharged. He was still intubated in the ICU, obviously not discharged at that point. Interestingly enough, when we look at the other supportive measures, some of these patients were on some very aggressive, very intense supportive measures. So that probably the most intensive support you can give to a patient with acute respiratory distress syndrome is veno-venous extracorporeal membrane oxygenation, or ECMO. If you're not familiar with ECMO, it's essentially an artificial lung. So you take blood, you run it into a machine, and the machine, as the blood passes through the circuit in the machine, it exchanges carbon dioxide and oxygen, reoxygenates the blood. The oxygenated blood then gets pumped back into the patient. So as I said, it's the highest level of critical care support we can provide to a patient. In addition, so there were 2 patients who were on veno-venous ECMO, and then both of those patients were also on continuous renal replacement therapy. So that's a very, very high level of support for both of those patients. The last thing is that all of these patients were on other antiviral therapies. So that includes, lopinavir, ritonavir, oseltamivir, interferon alpha, ribavirin, which is another antiviral that we sometimes encounter here in the US, typically for RSV. And then the last drug that you may see there that you may not be familiar with is Arbidol. Arbidol, the other name for Arbidol is umifenavir. It's an antiviral that's approved primarily in Russia and China, and it's used for influenza as well as a couple other viral diseases, but primarily influenza. So as we'll see, that's a huge confounder, the fact that these patients were on other antiviral therapies. So just some general outcomes. All 4 patients were eventually determined to be negative for viral RNA, and that occurred somewhere between 2 and 4 weeks after the convalescent plasma transfusion. Again, that's just an association. It doesn't necessarily indicate a causative relationship. So in other words, the administration of the convalescent plasma did not cause these patients necessarily to become negative for viral RNA. All patients tolerated their plasma transfusions well. There were no adverse events reported. So what are some of the limitations of this case series? Well, as you can see, it's a case series. It's not a controlled study. There were no quantification of antibody titers, neutralizing antibody titers, et cetera. And we'll see that some of the other studies we'll talk about do have some of those measures, which gives us a little bit more information. So this was really very descriptive. As I mentioned, all these patients also received other anti-COVID-19 directed therapies in close proximity from a time standpoint to the convalescent plasma transfusions. So it's very difficult to tell if the improvements were from these other therapies or from the convalescent plasma. It's a confounder that we're going to be unable to tease out and identify which one was really beneficial. Also, the level of support here was extremely intensive. This is, as I said, the highest level of support you can give an individual with current technology, and that was provided to 50% of the patients in this case series. So I'm not sure how representative of the rest of the world this particular case series is. If you look at most ICUs, 50% of the patients in the ICU are not on ECMO therapy at any given time. That would be incredibly resource intensive for any hospital to be able to maintain that. And at the time of the report, 1 patient was still intubated in the ICU, so not a complete resolution of symptoms, even though the patient was still alive. And this study only included patients with severe COVID-19 disease. So we weren't looking at patients with mild or moderate or even maybe who had just been exposed. So it's a very narrow slice of the total COVID-19 population that we're looking for answers in terms of what's effective. All right, so let's move on to our second case report. So this is a case report in 5 critically ill patients. So here we actually have some patient criteria to help us understand who these patients were. All patients had PCR confirmed COVID-19 disease. They had severe pneumonia with rapid progression and continuously high viral loads. They had an arterial O2 over inhaled O2 score of less than 300. And so that is one of the Berlin criteria for mild acute respiratory distress syndrome, if you're wondering where that number comes from. All these patients required mechanical ventilation. They also had some specific criteria for plasma donors. So we're going to get a little bit more information about the antibody levels and the types of antibodies in these particular donors. They had to have a serum anti-SARS-CoV-2 antibody titer of greater than 1 to 1,000. They also had to have neutralizing antibody titers of greater than 40. So if you remember a couple slides ago, we talked about the difference between neutralizing antibodies versus just anti-SARS-CoV-2 antibodies. So they actually did test for neutralizing antibodies. So we know that the antibodies from these donors was able to prevent viral infections in cell lines. So the intervention, the patient received 2 transfusions that totaled 400 mLs of convalescent plasma. So a little bit more well-defined than the last case series that we heard about. So this is a table that presents some of the characteristics and some of the initial clinical course of these 5 patients. I'm not going to be able to go into too much detail just because of time, but we've got 2 females and 3 males. The age range is between the 30s and the 70s. Average age is probably in the 60s. If you look at the past medical history, it's interesting that 4 out of the 5 patients have no significant past medical history. 1 patient did have hypertension and mitral valve insufficiency. In this study, they were actually able to trace the time course between exposure and the appearance of symptoms, as well as the difference between symptom onset and hospital admission. And then they tracked the interval between hospital admission and the convalescent plasma transfusion in terms of days. They give you a list of some of the complications that these patients had prior to receiving their convalescent plasma transfusion. So pretty commonly, all of them had acute respiratory distress syndrome. One patient had multi-organ failure. Several of them had bacterial pneumonias, and one patient even had a fungal pneumonia. So pretty severe patients, all listed as critical. And you can see all these patients received a number of different therapies, including steroids for the management of ARDS, as well as anti-COVID-19 directed therapy. So another huge confounder, again, for this particular case series. We're not going to be able to pick apart whether the outcomes that we see are due to these other antiviral therapies or the convalescent plasma transfusions. So here we look at, again, their clinical course, and we see how long they were intubated before they received their convalescent plasma transfusion, and then how soon after their convalescent plasma transfusion they were extubated. And 2 patients at the end of the study remained intubated, and the other 3 were extubated either 2 days or 9 days after receiving their convalescent plasma transfusion. One patient was also on ECMO, so again, pretty significant level of support there. Interestingly enough, they also measured IL-6 levels in these patients pre and post convalescent plasma transfusion. One of our last episodes of this 15 on COVID-19 series was looking at the role of IL-6 antagonists in COVID-19. So I threw that in there just as a point of interest for those of you who would like to see that. Of note, they did see significant decreases in IL-6 levels after the convalescent plasma transfusions. And then at the end, they talk about their length of hospital stay and their current status. So 2 patients remain hospitalized, and they're still they're stable but receiving mechanical ventilation, and 3 patients were discharged home. So overall, mixed bag there. Some of the limitations from this study are going to be very similar to the ones from the last study. This is a case series. The patients all received other anti-COVID-19 directed therapies, again, in close temporal proximity to the convalescent plasma, so it's difficult to say whether any benefit was from the convalescent plasma or from these other therapies. And again, very intensive support measures provided to 1 out of 5 patients in this particular case series in the form of ECMO. They did a better job in this series of identifying their donors and having some more standard criteria for the patients who are included. So that's one benefit of this particular series over the previous series. All right, so our last case series that we'll be talking about is a case report in 10 patients who had severe COVID-19 disease. So again, we've seen a pattern of critically ill, severe, etc. So not much in the mild or moderate category and none in the prophylactic category. So who are the patients? 6 males and 4 females admitted to the ICU. The median age was 52.5 years. The age range was between 34 and 78. The median time from symptom onset to hospitalization was 6 days. The range was between 0 and 10 days. The median time from symptom onset to convalescent plasma transfusion was 16.5 days. The range there was between 10 and 20 days. The comorbidities for these patients: 3 patients had hypertension, 1 patient had cardiovascular disease and cerebrovascular disease, and 6 patients had no previous medical history. All patients received antiviral therapy, so very similar to the trend we've seen in the other case reports, and 5 patients received more than 1 antiviral therapy. 1 patient received 4 different antiviral therapies prior to the convalescent plasma transfusion. So again, it's going to be very difficult to determine whether any improvements were due to the convalescent plasma transfusion or some of these other interventions. So who were the donors? Again, we've got some more information about the donors here. The donors had to have normal temperature for more than 3 days. They had to have resolution of respiratory symptoms. They had to have 2 consecutive PCR tests for SARS-CoV-2 viral RNA spaced at least 1 day apart. And They had plasma collected either 3 weeks after illness onset and at least 4 days after discharge from the hospital. The intervention was one 200 ml infusion of convalescent plasma with a neutralization activity of greater than 1 to 640. So again, we've got an actual neutralization test here demonstrating that the antibodies from these donors can in fact prevent infection of cell lines with the COVID-19 virus. So what were the outcomes? I'm going to read directly from the paper here. All symptoms in the 10 patients, especially fever, cough, shortness of breath, and chest pain, disappeared or largely improved within 1 to 3 days after the convalescent plasma transfusion. 2 patients were transitioned from mechanical ventilation to high-flow O2 via nasal cannula. 1 patient was able to transition from high-flow nasal cannula to conventional oxygen delivery via nasal cannula. And according to the authors, all patients demonstrated radiographic improvement on chest CT. So here is one figure from the article, and it's 2 patients. And on the left-hand side of the image, this is panels A and C, are the CTs pre-convalescent plasma transfusion, and then panels B and D show the same patient's CT scans after convalescent plasma transfusion. If I remember correctly, panel B is 6 days after convalescent plasma transfusion, and panel D is 10 days after convalescent plasma transfusion. So there's some significant improvement in the CT scans for those patients. So what's the bottom line on convalescent plasma for COVID-19? So, as has been so often the case, evidence is really only available in patients with severe COVID-19 disease, so we don't have a lot of evidence in mild, moderate, or again in prophylactic use. It's anecdotal. So everything that is out there is not controlled. It's not done in a controlled fashion. There are no comparator groups to speak of, and so it's very difficult to interpret the data. The biggest thing to me is the significant confounding factors of other antiviral therapies being administered. So it's really difficult to tease apart the benefit of convalescent plasma as compared to some of those other interventions. So to my mind, it's really impossible to demonstrate the true benefit of convalescent plasma without including those other steps of antiviral therapies. And bottom line is that we still need more studies to really answer the question as to the benefit of convalescent plasma for COVID-19. And as it turns out, like with everything else right now, there are a number of randomized studies looking at convalescent plasma in a variety of different settings. So again, mild, moderate, severe disease, as well as pediatric patients with COVID-19. So too soon to tell. The early data shows some promise in severe patients. It seems like they do better, but again, it's impossible to know how they would have done if they hadn't gotten the convalescent plasma transfusion. So it's anecdotal data, and really that's about the best you can say, especially with the confounding factor of the other antiviral therapies. So with that, we will wrap up today's episode of 15 on COVID-19. Our topic for this Friday, April 17th, we're going to do a review and update. We're going to go back at some of the topics that we already talked about and take a look at what data has emerged. This is such a rapidly changing space that what was true then may be true now or maybe not. So join us on Friday and learn more as we revisit some of those topics and see what the new evidence is telling us. If you have questions about COVID-19, we would love to hear them. Please email us at covid@aphanet.org. We continue to monitor that email address every day. Thank you so much for joining us. We look forward to seeing you on Friday.